Let's look at several of the most common problems that affect the nasal cavity and sinuses and explore solutions to these problems. Your nose is primarily an air passage, but in order to be successful, the airway must remain clean, humidify, and warm the air, and it must also handle undesirable particles such as dust, pollen, bacteria, and viruses. It should come as no surprise that problems can arise. One of the most common problems is the common cold. The average adult gets 2 colds per year, and children in daycare can have 10 or more viral infections per year. The rhinovirus is a single-stranded RNA virus, as is the coronavirus. A common event that can lead to catching a cold begins with unwashed hands. After touching a contaminated surface, you rub your eye and touch the mucous membrane in the corner of your eye. People do this all the time. The rhinovirus travels with your tears into the nasal cavity where it begins to spread and causes swelling and increased secretions. In some rhinovirus infections, only the nasal cavity is involved. The septum, turbinates, and other surfaces become inflamed and swollen. Secretions increase. The space between the structures narrows, causing congestion. In most viral infections, the swelling, increased secretions, and inflammation extends into one or more of the sinus cavities. Viral infections that involve the sinus cavities may be the most common type of sinusitis. However, when healthcare professionals use the term sinusitis, they're usually referring to a bacterial sinus infection, and in most cases, antibiotics are prescribed. Here we see swelling and excessive mucus production that is extended into the maxillary sinuses, but no collection of fluid. When the sinus cavities become inflamed, even as the viral infection begins to clear, it is possible for one or more of the cavities to become obstructed and fill with a puddle of liquid, often referred to as an air fluid level. In a small percentage of rhinovirus infections, the pooled secretions provide an environment for bacteria to gain a foothold. An acute bacterial sinusitis has developed. In most cases, when bacteria become involved, the body's immune system successfully clears the infection in a week or two. The fact that bacterial infections usually resolve without antibiotics is underappreciated. In some cases, antibiotics are warranted if the process is taking too long or if the symptoms are severe. Persisting bacterial infection can lead to the simplest form of chronic sinusitis, chronic bacterial sinusitis. When inflammation and swelling block the drainage pathway of one sinus and the infected mucus cannot escape the sinus cavity, a chronic sinusitis has developed. At some point, it becomes clear that medications will not resolve the infection. Surgically opening the sinus may become necessary. Here we see a common endoscopic sinus surgery procedure. An endoscope is used to examine the site of the obstruction, in this case, the right maxillary sinus. In almost all sinus surgeries, the details of the anatomy and the condition are already known from a preoperative CT scan, an essential part of the workup for chronic sinus problems. An instrument called a backbiter is used to remove portions of the uncinate process, and then a microdebrider is used to remove additional portions of the uncinate and parts of the maxillary sinus wall. The debrider bites small pieces of tissue and sucks the piece down the tube. Once the drainage pathway is clear, the sinus usually returns to normal and is left with a larger-than-natural opening. If the ethmoid sinuses become chronically infected, they can be surgically opened by removing the thin bony partitions that separate the ethmoid cavity into small cells. This creates one larger space that is less prone to obstruction and contains less overall mucosal surface area. Both powered and manual instruments are often used for this procedure. One of the technically more difficult sinuses to open surgically is the frontal sinus. Chronic frontal sinus obstruction is dealt with by removing the obstructing ethmoid cells in the frontal recess. Once the pathway is clear, the mucosal swelling and fluid collections will often resolve. There are specific instruments that are used to open each of the different sinuses. In addition to traditional sinus surgery with removal of obstructing and diseased tissue, some surgeons utilize balloon systems to stretch narrow openings and to crush obstructing ethmoid cells, creating more room for drainage. The balloon systems are touted as a less invasive technique, but most experienced sinus surgeons prefer removal of obstructing tissue. In some patients, the mucous membranes respond to inflammation by forming nasal polyps. Nasal polyps are benign inflammatory growths that represent focal swelling of the mucous membrane. In their most dramatic form, they can be seen protruding from the nostril. More typically, they are concentrated in the upper nasal cavity and can only be seen on nasal examination. During a standard nasal exam, if the head of the inferior or middle turbinate is enlarged, it can be mistaken for a polyp. Unlike polyps, enlarged turbinates are usually reddish in color, whereas inflammatory polyps are more often pale gray in color. Polyps can obstruct airflow, they can block sinus drainage, and they can interfere with the sense of smell. Steroids usually shrink nasal polyps and can provide some relief. Oral steroids are most effective, but steroid sprays are helpful. There are several underlying types of chronic sinusitis that can lead to polyps. Patients with prominent polyps have one of the most difficult sinus problems to treat. Airflow is what the nose is all about. It functions best when the slot-like passages on each side are shaped correctly. The nasal septum sits between the left and right airway. Deviations in the shape of the nasal septum are a common cause of airway obstruction. Nasal septum deviations are often blamed on injuries, but many times there is no clear history of an injury. When the nose is impacted, such as in a sports injury, fight, or simply birth trauma, the impact occurs to the front of the cartilage, but the force is transmitted farther back, often causing deviations well away from the actual impact. There are several typical configurations that a deviated septum can take. The C-shaped deviation. The caudal deviation. Caudal means the anterior-most part of the cartilaginous septum. The S-shaped deviation. The nasal septum sits in a trough of bone called the maxillary crest. Imperfections in the alignment of the septum here are common and can cause problems. The septum can be off of the midline, or the trough of bone itself can be off of the midline, or they are often deviated together. Each of these configurations can cause airway obstructions. Another common abnormality is an isolated ridge of bone called a septal spur. Septal spurs can cause airway obstruction, but they can also cause referred pain if they indent the inferior turbinate. Cartilage supports the nasal profile. An L-shaped portion of the nasal cartilage must be maintained or reconstructed to prevent collapse of the nasal profile. Deviations of the cartilage at the critical nasal valve location can obstruct airflow with minor misalignments and can be especially challenging to correct. Repairing a deviation usually begins by making an incision in the mucous membrane and carefully elevating it off of the bone and cartilage. Once it is accessible, the off-center portions of bone are removed or repositioned. Cartilage is straightened using various techniques. Once the deviation is corrected, the mucous membrane is returned to its original location and sutured into place. The inferior turbinates tend to change size over time to fit the available space. They often fill the concavity of a deviation. When a deviated septum is restored to the midline, the previously more open side can become obstructed because of the size or position of the middle and inferior turbinates. A turbinate reduction is often performed in conjunction with a septoplasty to create a symmetric airway. Turbinate size can be reduced using several techniques. A turbinate reduction can be helpful to improve the nasal airway in several situations and is often done as a standalone procedure. Here we see a common method for turbinate reductions done under anesthesia. The microdebrider is used to carefully remove the excessive tissue from the bottom of the turbinate, and the plasma wand is used to shrink the remaining portion. When the turbinate heals, it recontours into a smooth surface. It is important not to remove too much tissue, as the turbinates have a vital role in humidification and airflow regulation. Nasal packing is an important tool in some types of nasal surgery. There is bleeding with most nasal surgical procedures. In many cases, the bleeding is brief and minor and stops with natural clotting. In cases where there is more persistent bleeding, packing is often required. Packing applies pressure to the site of bleeding and reduces the flow. There are several different types of material that are used as packing. One of the most common is a sponge made from cellulose. This type of packing starts out firm and narrow. Once it is inserted, it is wetted with saline, afrin, or blood. The sponge expands, becomes soft, and applies gentle pressure to surrounding structures. Patients have often heard terrible stories about packing, but in most cases, packing does not add much discomfort. It is best when no packing is needed because there is less of a pressure feeling and more airflow. The sponge is placed in position in its dry form and then expands to provide pressure. Packing against the inferior turbinate is often placed after a turbinate reduction or septoplasty, and packing under the middle turbinate is placed for sinus surgery. Packing is usually removed in 1 to 4 days in the office.